I'm Dr. Jeremy Northup from Point Park, and you could do your own introduction.
I'm Anna Kreienberg. I'm at Duquesne.
Yeah. So we're involved in a kind of ongoing 18-month study of kind of the intersection between systems of care and those who receive care. And so this is our presentation. Again, it's like pretty bare bones because there's emergent sorts of themes. We don't really have any sort of we haven't done comprehensive data analysis, but we're kind of beginning to skim the surface of the data that we've gathered already. We've interviewed 30 service providers, and we'll interview 30 people with lived experience, people with homelessness experience and precariously housed experience. So we'll have some kind of tentative themes here, and I'm seeing if I have anything else to say by way of introduction. I think it's interesting that Craig Steele gave the presentation here in Pittsburgh. As you know, Steel City and the Pittsburgh Steelers. This is something that I've wanted to say for a very long time. It's at the top, literally at the top of my notes. So it's a bye week for the Steelers, but Craig Steelers is in town. Okay. Do you want you want me to have the thing?
Please.
Okay. Okay, so what is our first slide? Let's see.
We're talking a little bit about just sort of flow of our talk. Jeremy's going to talk a little bit about how the project came to be. We're going to give a little bit of background to what homelessness and housing precarity looks like in Pittsburgh right now. We'll talk a bit about the current study, and then we'll go into some of the major things that are coming up, especially again from this sort of how service providers working in the field, largely people who are doing harm reduction, people who are providing mental health care to people experiencing housing precarity, are sort of seeing the field and seeing sort of what steps we might take towards especially creating a new way of implementing mental health services in what we're calling a street therapy program.
Yeah. So I don't know if you have a slide for how the project came to be. No, we don't. So I'm just going to talk a little bit about, see if I got this right. The thing is with this, you can't hit the button with the, you can't hit that button apparently. Okay, so yeah, so how the project came to be. So like so many things, this came to be in graduate school for me. So I had to take a program development course. And we had to come up with a program. We had to develop a program, and I was like, oh my god! At first, I wanted to do some sort of socialist Boy Scouts program or something like that. And immediately, someone was like, you should do something that's going to be relevant for your doctoral studies. And I was like, nah, I don't think I'm going to do that. And then I ended up doing that, of course. So I came up with, I did a literature review for what a street therapy program can look like. You'll see that we're using the word therapy here. It's kind of interchangeable with psychotherapy, but I'm like heeding the warnings of the crowd today that this doesn't necessarily have to be an individualized therapy. It can be a therapy that looks kind of broad in various ways. It can look like a social therapy. It could look like transforming communities. It could look like any number of things. It doesn't just have to look like two people in some sort of psychoanalytic frame therapy space. So I came up with this in program development. I wrote the paper, did the paper, whatever. Nervousness. I'm actually legitimately nervous here. So, okay. So bear with me a little bit. So then Calla went on to get her master's in clinical work, and I went on to get my doctorate. And then we came back together and we dreamed this up together. So lots of car rides talking about the need for street therapy or interventions that are kind of not traditionally clinical in the way that you would understand them now. And then we got this grant from the James L. Hillman Foundation for an 18-month project. We hired Anna, who seriously, we did a hearing voices training, and Anna organized this hearing voices training here, and just like immediately wanted to do the work. And we were like, we couldn't have picked anyone better. So Anna joined in to help us with this work. And yeah, and so the grant goes from the beginning of the year through the summer of 25. So we have an 18-month study where we're doing like kind of, informal hour-long interviews with people who have experienced homelessness and housing precarity, and then also with service providers that luckily Calla has this kind of deep-seated connection with. I mean, she's been doing street outreach work and harm reduction work with the Pittsburgh community for, frankly, like 7-8 years, and is like, one of the exceptional individuals that we will reference on one of the other slides, kind of as one of the themes that shows up. Just looking here for Yeah, also, so when I was in my master's program, I did an advocate ethnography project. So we rode along with people who were involved with Operation Safety Net. So this is some of the data that I'll speak about here. I'm kind of, grabbing from various different studies, but we were in the backs of cars, we were going to encampments, we were interacting with police officers, we were interviewing those with lived experience who were living in camps all over the city of Pittsburgh, very close to here actually. And so we were doing, and the point of this was to advocate, so even at that beginning nascent stage, we were thinking about what it's like to actually not just kind of collect data in the dusty realms of academic journals that no one reads. Unfortunately, I haven't read most of the papers that people are even presenting on today. And I'm at the ISPS conference, So it was more than that. It's about transforming the kind of ways in which homelessness is related with as a phenomena, and doing that phenomenologically. So this is the kind of backstory for how the project came to be. And now Anna can talk a little bit about some of the numbers of Pittsburgh and homelessness and things like that.
Yeah, so every year Pittsburgh, among other cities in the US, collect a point in time. Oh my God. This is a wrong.
Oh, good. Whatever. There's supposed to be charts here.
There's supposed to be charts here. And so the main thing that we're thinking about is the people experiencing homelessness in Pittsburgh since has been like steadily on the rise since 2021. Unsheltered homelessness specifically has increased over 100% since 2021. And despite the fact that Allegheny County is really abundant with services to address mental health concerns, we have really strong harm reduction and overdose prevention programs. Prevention Point is a really powerful organization in that realm, especially among others. We have these amazing street medicine teams. Like street medicine kind of has a history you can even track back to Pittsburgh. Yeah. And so this includes physicians going out, psychiatrists, nurses, people who are sort of providing medical care in a really ongoing way on a weekly basis. A lot of people around on a weekly basis, and we also more recently there's been a program with law enforcement that includes like a correspondence with a social worker for certain crisis situations. And so even though there's all these great services that are supposed to sort of address the needs of a growing number of folks who are experiencing homelessness, our concern with these, and part of why we're doing this project, is because these are programs for immediate crises, and they're short-term, they're temporary solutions, and they're limited by this sort of medical and biological approach to suffering especially. The graphs that we had were just visual representations of that increase since 2021, reflecting the sort of concern with sort of helping folks out and addressing the need there. But also there was another little graph that talked about when they do the point in time survey, they'll ask some folks who are experiencing homelessness, how do you understand homelessness? Why do you consider, like, why do you think you're still sort of struggling to become housed in an ongoing way? Kind of a ridiculous question in a way. I mean, it's kind of a wackadoo question to ask, but for the people who choose to answer, a huge portion of that graph is people reflecting like, my mental health concerns make it really hard for me to stay stably housed. So of course, housing is a concern. Housing in Pittsburgh is kind of, we're kind of in a crisis in terms of expensive housing, ongoing privatization, forcing people out of the city, and also getting people forced out of their homes. Housing is a big concern. Like good employment, quality employment is a big concern. And then the third biggest concern is people's mental health experiences as they see them. So another reason why something that's a more ongoing kind of care is necessary.
Yeah. All right, what's this one? Okay, so this is a little bit more about what the actual, so how are we kind of, I think of this a bit as the research itself is a bit of an intervention, to actually interrogate what it is that may be happening, what kind of links are being missed, what the care infrastructure looks like in a more general sense, and some of the data that we received, and we'll talk a little bit about this later, is like people who are doing the work on the street every day have to be kind of prioritize pragmatics, and then therefore don't have a very good depiction or picture of what kind of services exist. So part of what we're doing is trying to get the lived experience of people who are experiencing housing precarity in relationship. I mean, and once you're talking about housing precarity, I know it's psychosis, schizophrenia conference, you're almost immediately talking about those sorts of diagnostic criteria. You know, people would be diagnosed with psychosis, schizophrenia, among many other diagnostic categories too. So we're looking for those experiences, but also kind of just to really paint a picture. I mean, I'm of what the service landscape looks like, and to help the people who are interviewing with us understand the service landscape also. Because, you know, we shouldn't just assume that if someone is speaking, they know what it is they're speaking about, you know? So there's all sorts of these really interesting perspectives about what people are saying the landscape is, but then other people are directly refuting that in other interviews about the kind of flow chart of how human beings move through these systems of care. So, you know, so this is a qualitative research study. You know, we're using phenomenological, hermeneutic phenomenological methods. I was just talking with Pim earlier about how, you know, they feel like, you know, they should have all these slides up here for method. And I'm like, you know, we have really none of them up here. I'm also looking directly at Elizabeth Fine too, as I'm saying that. So why? So like most of us, you know, and let's be clear here, there's not some sort of drastic dichotomy between the people who are the undiagnosable and the people who are the diagnosable. Like, all of us probably meet criteria for some mental health diagnosis. You know, so this was, I think there was something on here like 75% of people, but I think all people who live on the street could meet, you know, criteria for mental health diagnoses. I mean, like, I could, Anna could, everyone could. I'm up here having like panic attacks about this presentation. So of course I could meet some sort of criteria for this. So Bridge Outreach reports that nearly 90% of their clients have been diagnosed. You know, so this is like, you know, almost all people that Bridge Outreach, Bridge to the Mountains, which is you know, an outreach organization that does harm reduction services. I think Anna talked about that earlier. 9 out of 10 people are already diagnosed. They're walking around with some of the, you know, the most heavily sort of stigmatized diagnoses that exist. So, you know, sustainable, safe, we'll say about this a little bit more on the next slide, but sustainable, safe, and quality mental health services are non-existent. And it's not because we've deconstructed them. You know, Nev so nicely spoke earlier about like needing to challenge the idea of mental health services, psychotherapy, but frankly, there isn't already. You know, so it's like we haven't won the battle and there's no psychotherapy services. Psychotherapy services, for, at least in my opinion, for this population would be an upgrade. And frankly, what we have is something even subpar from that. We don't even have what any of us would accept as traditional, even decent psychotherapy for us, let alone to begin to imagine, I think, what kind of changing and challenging the script of psychotherapy might look like. And I think all of those things are in this kind of broader hermeneutic circle. It's not like the individual or the culture. It's the individual and the culture, the ways in which the individuals are always already cultured. If we kind of aim at either one of those, we end up probably with a piecemeal sort of, I don't know, situation. So qualitative approaches, you know, can provide complicated relational understanding, and psychological research related to homelessness, typically focused on causes of homelessness, and is usually in hospitals, jails, and shelters. You know, but we have the privilege, you know, working with Calla from Bridge to the Mountains, to have access to, I mean, like, not even just access to people with lived experience, but like people that she's been working with for 7 and 8 years in kind of the worst, you know, moments of their lives, which are often far more frequent than we would like to imagine, but really kind of able to leverage intimate relationships that Calla and others have formed through their outreach work to try to get some real kind of data from inside sources who are experiencing this day in and day out. Yeah, and I don't know if you have anything you want to add there.
Yeah, I just, I kind of want to speak again to I think it's really important, this idea that, you know, 90% of people that Bridge is working with are already diagnosed. And there's, I think, a lot of research into the phenomena of homelessness that really wants to think about the sort of like bi-directional relationship between mental health and homelessness. And you'll hear the research, kind of some of it, talk a bit about, well, mental health concerns, especially serious mental illness or psychosis or substance abuse problems, actually cause homelessness. And newer research really says that's not a good way of understanding this. And so I think research that like really focuses on this sort of causal thing is not so helpful. What we're really trying to paint a picture of is, of course, experiences of homelessness that might put you into traumatic situations, might represent some of the hardest moments of your life. They're going to have an impact on your mental health. And what we really want to do is capture the sort of stories of folks and the people who are caring for them are sort of understanding that and seeing that, against sort of more mainstream research that says like, well, mental illness caused this, and everyone who's homeless is this kind of mentally ill. We know now that that's really inaccurate. Yeah.
Yeah, I think it's also just like what's nice about qualitative work is that it's almost in some sort of sense fundamentally anti-reductionistic.
Yeah.
You know, it's like there's this urge, you know, and I feel the urge too to figure out a cause of any number of things, the cause of you know, someone's trauma, the cause of homelessness, the cause of this or that, and you know, it shouldn't be news to anybody that's like it's plural. There's a pluralistic genesis to these conditions, and I mean that in the broadest of senses. And I think qualitative research, you know, it's so frustrating doing phenomenology because, you know, and some of the stuff that we're going to talk about today is kind of readings of phenomenological reports. But phenomenology often has this kind of naive quality to it, and I'm listening to people talk, and I'm like, you can't possibly think that. But then I have to think, well, they did think that, and they said that, and that's kind of nice in a lot of ways because it's a way for me to kind of disrupt this kind of, I don't know, the schematizing of my own sort of prejudgments in the Gadamerian sense. So yeah, I love this qualitative, I don't really know, like hesitation or something like that, which is really nice. So many causes probably, you'll probably hear about a lot of them over the length of this conference, causes that, you know, help us as clinicians, help us as researchers, help us as you know, scholars and any number of things. But, you know, nobody really knows what causes much of anything. And qualitative research largely brackets the question of causality in the first place. So yeah. All right, so next slide. Okay, so Calla was going to do this slide, so I'm going to do my best with this slide. You know, I have this professionalization. There's this increasing professionalization. I think when Nev was talking earlier, I was thinking a lot about this. It's just kind of like we make a lot of jobs when we kind of professionalize all of these people's lives. We come up with new professions to solve new problems. You know, and so you know, services in Allegheny County have continued to grow exponentially over the past 10 years. This is good in a lot of ways. You know, you can actually get harm reduction services. You can get access to medical care. You can get street outreach. You can get psychiatry. This is good in a lot of ways. The city and county have both developed programs to directly engage with myriad aspects of housing, health, and safety. You know, Pittsburgh is well stocked in programs related to homelessness and serious mental illness and any number of different, you know, buzzwords we want to use from a county and city kind of perspective. So many of these teams include licensed mental health practitioners, including co-response teams comprised of LSWs and police officers, blended service coordinators. So this is like, you know, it's kind of like, you know, every single kind of, you know, clinic has their own sort of blended service, vaguely wraparound sort of niche focus, you know, that on the one hand is like more individualized, but on the other hand ends up being kind of siloed. So every sort of clinic has their own sort of way that they're doing this outreach program, which then of course puts a lapse in between the communication between these different services. You know, and they're all kind of increasingly behavioral health focused, you know, whatever that is vaguely going to mean, that works increasingly with specific populations. And continually more and more services are deployed under the guise of behavioral mental health care, and none of them are. So like there are, like, I'm not playing around with you, there are like maybe one therapist dedicated to the entire population of those who are experiencing housing precarity and homelessness in the city of Pittsburgh. Of course, there are people who are therapists who work with those who are experiencing homelessness. They're not interchangeable. But you know, there is one at 2nd Avenue Commons which just recently had a fire, which is one of the shelters and kind of spaces where those experiencing homelessness can be, and has recently been displaced, and he's doing largely all of the work there. So this is the curiosity that we're kind of mentioning. I'm kind of pointing out here is that while there's been a kind of increasing service provision or provisions of services for people in Pittsburgh, including those related to behavioral health, including those related to harm reduction, including those related to food and medicine and psychiatry, none of it is psychotherapy. You know, and this is what's so interesting to me. It's like either psychotherapy is like, well, there's probably any number of reasons, but like, you know, either we've deconstructed psychotherapy and we've moved it to fully, we finally realized the utopia of community-based mental health has been realized, or there's like a systematic disregard for what I think psychotherapy can look like that I think lots of people traditionally have a misunderstanding of. And people aren't being provided what I think is meaningful street therapy. What that means is therapy that's related to meaning and not causality or behavioral health or whatever that heck people are talking about, and that also has a meaningful impact on people's use of those psychotherapeutic services. So that doesn't necessarily have to look like a traditional, I don't know, like a Lacanian psychoanalysis or something like that, but it does have to have a meaningful impact on people's lives, and it's just not at this point. So
It could look like a Lacanian.
it could look like a Lacanian, but it doesn't have to look like a Lacanian psychoanalysis.
It might.
But it doesn't have to be. Okay. We're in the Duquesne crowd here. But yeah, so this slide is just to say, like, there are increasing numbers of people who are employed in the kind of in the service industry related to homelessness, yes. But yet there is not money going to doing psychotherapy, long-term, humanistic, meaningful, phenomenological, experience near psychotherapy that any of us would want to send our friends and relatives to for those experiencing homelessness. Like, I encourage you to find me some in the city of Pittsburgh. I would love that if you did. Okay. So do we just have, is this like our next to last slide? No, we have 2 slides, right? Yeah, okay. So Anna, whenever you want to jump in here on any of these 2. So these are kind of tentative emergent themes that we came up with. They're kind of, I tried to think of like sexy titles for these themes, so I'm especially kind of excited by more than Maslow, not quite Descartes. That's a fun one to me. So these are tentative emergent themes. They're kind of from the data that we got from the interviews with service providers. Again, we have not conducted the interviews with those with lived experience, though I have worked with that population for a long time, and Kala does, and so lots of kind of experience, working with people with lived experience of homelessness. But this is largely confined and related to those who work with those experiencing homelessness. So the first theme is familial supplement. So in the data, and I'm sure Anna probably has something to say about this too, but in the data with those service providers, one of the things that we noticed kind of quickly was that there's this kind of interesting way that people talk about the people that they work with. This is not just those who are psychotherapists, but also we talk to medical doctors, we talk to social workers, we talk to people who are working harm reduction, we talk to, I'm trying to think of other people we might.
People who work as blended service coordinators, doing wraparound programs, helping provide housing for folks,
housing,
shelter system folks.
Yeah, so we're like interviewing them to both get the shape of the kind of care infrastructure, but also to see the ways in which they're kind of doing psychotherapy in a kind of tacit sort of space, but also to try to like think about the way that they would imagine, and one of these things later on, they would imagine what a psychotherapy service could look like, and frankly, they had often had a very difficult time doing that, which is interesting in and of itself. So familial supplements. So one of the things that we notice, and psychotherapy is often thinking about one's family, is that those who are working with those who are experiencing homelessness was that they would often talk about the people they were working with as if they were family members. This is a really interesting thing to think about. So they would be doing things that one who might have more kind of close relationships with their family would do for them. So, if I broke my leg, I would hope that maybe Anna might drive me to my doctor's appointment. Or I would hope that maybe Kala would drive me to my doctor's appointment. But often for those with lived experience, people who are experiencing homelessness, they don't have that. So they're often looking for really just help in a familial setting. Like they're looking for things that their family members would be doing for them and with them on the one hand. So that's the kind of lived experience side of it. The other side of it is that, interestingly enough, the people who are working in the services were also kind of looking for family members. And this is really, like, there was something about, and I don't mean this in like a creepy sort of boundary breaking way, but that there's almost this nascent theme of familial proximity that emerges in the data, which I don't really know what to make of it yet, but was available. I mean, one person talked about literally being with their kids in the car and driving through Pittsburgh and seeing one of their patients, picking them up and driving them somewhere with the person. Like, so literally, like, all in the car, like all in a family, like in the car being driven to where they have to go. And this, I don't think she was the only one, but I don't know if you have anything you want to add here.
No, yeah, there's actually another story where someone sees a patient that they're treating when they're walking with their family past a camp, and they just go to check in. And it's like, there's not these separations that we might imagine, especially from a psychotherapeutic context of like boundaries or, whatever fascinations or imaginations we have about like how the like the way these boundaries would look, they kind of get like super broken down. Yeah. Absolutely.
Yeah. And this is like related to the next theme, actually, because we had various stories related to this next one too. So the continued urge to be exceptional and beyond. So this is really important, this kind of slash beyond and then undefined roles. So it was like people kept going kind of above and beyond constantly for this job, outreach or service provision or whatever it is. And so this is really wonderful in some way, but also people then were like really nervous about what the hell their job was. So while they were going above and beyond, they were also like, oh my God, I'm being invaded by the need to do for people all the time. So there was one person we spoke with who on their commute to work in the morning would go by people who they knew, and it was almost like even the commute itself was this, that they should be like off, should park and go do the work that they have to do like on their way in the morning before they've gotten a cup of coffee, because there is this constant need, constantly, all the time. But then also this creates a certain sort of anxiety about not quite knowing what I should be doing, because I should be doing basically everything all the time. And so you have these exceptional individuals. Every single person we talk to, I would consider one of these people that just goes above and beyond all the time. They're like 2 phones kind of people. You know these people. They're they got 4 phones. They're this is their work phone. This is their other phone. They're constantly getting messages that are from random numbers that they gave from some, and they're and then they're they're constantly, again, bombarded with in the kind of, in the broadest of senses with anything that could happen at any moment on the street, that they are the only person that can take care of it for them.
And that is, I think, especially emerged as a theme in conversations about deficits in other services. So you have people being like, I need to check in with a bunch of folks today, but I also have someone who needs to go to the ER in crisis. And if I don't go to the ER with this person, something really, really bad might happen to them upon admission. And so I need to be there to advocate for them. And so I think that it puts people in these terrible binds. And they're one kind of thing that comes up is in order to address what some of the navigating across the hospital, the housing program, case managers have case managers in this kind of landscape, managing the deficits of these other programs, because the roles are so loosely defined and vague, makes people have to step up constantly. And there's a lot of soft skills training that people who are really good, especially at outreach, about making relationships, focusing on relationships with people, and then bringing them sort of the material needs that they might need transportation, they might need socks, they might need help getting to the doctors for an injection. There's those people who are really, really good at making those relationships, they tend to go spread that knowledge to other people, but they reflect a little bit to new workers, but they reflect a little bit of guilt, or I don't want to transmit the fact that you are completely responsible in some ways to other people, because that's kind of burdensome and the system shouldn't work this way. So it's a kind of interesting sort of generational, inherited trend that people are, feeling like they have to step in to address these deficits in the systems, but also there's no place where it stops. Where's the buck stops with them, and then they sort of pass that on to new outreach workers, and it gets really hard to be how do we actually systemically address this, because it's mostly a lot of individuals stepping up exceptionally.
Yeah, I mean, if we're putting neoliberalism on slides, I mean, if that is the kind of essence of it in so many ways. It's I am the only person who can do this thing, and I have to take this home with me always, and I always have to be on. And this kind of, I don't know, this merging of effective economy with pay economy, and also further, it's people, if someone needs to quit their job, because jobs are jobs, even when you're working in, these kind of really kind of moving and meaningful spaces, often when they quit, all of that knowledge goes, all of those relationships go. So the burden is further kind of heavied, I guess, because they have to be exceptional, but then they also can't kind of leave, because if they leave, then those connections are kind of thwarted. The relationships that the people we talk to, the relationships they're building, would make psychotherapists jealous, frankly. The ability to make relationships with the people that they're working with is dramatic and astounding. And then when those people leave, there's not this kind of institutional support because it literally rests on the back of all the individuals who are involved, which I think to me is in so many ways just kind of, the lacks in care are then picked up by exceptional individuals in what to me is largely in so many ways like essential to the kind of traits of neoliberal subjectivity. So yeah, so the next theme is lack of continuity, misunderstanding, and the care ecology. So there's there's a lot of informal relating that happens, like a guy who knows a guy who knows a person who knows a whatever, but there's not a lot of kind of sense of how they thread together. So speaking specifically to psychotherapy, one person would say, when you need care, you go to this place. You send them over to this place for an intake or something like that. And then, so we talk to someone who maybe works at the place who does the intakes, and they're like, no, you send someone for intakes, but the person's like, I can't get in, right? But then you talk to the person who runs that place, and they say, everyone gets in. And so we're sitting here and we're like, wait, like how can all of these things be true at once? How is it so people who are on the street who are working with those lived experience, who are asking for psychotherapy, like, and there's some, I think Anna has some quotes here at some point, who are asking for psychotherapeutic services. They want psychotherapeutic services. They're speaking to their service coordinator, their outreach coordinator, their harm reduction person, or whatever it is. And they're saying, okay, go to this place for psychotherapy. But then that person can't they either don't, oh crap, we got 10 minutes, okay. So they can't get those services, or they don't, there's not a good understanding of how those services are acquired. I don't know if you have anything.
No,
Yeah, okay. So iatrogenic institutional interactions, not surprising to anyone here. Our institutions as they exist right now are terrible. And they're harmful, and they cause more harm than they help. And they, I don't need to speak a lot about this theme because I think largely so much of what we're going to talk about here addresses this theme. The institutions that are supposed to be helping are harmful, and this can go back to old psychoanalytic work and also into contemporary understandings of interventions. So I have more than Maslow, not quite Descartes. There's this sense in themes that if we just get people's bodies right, then all their psychological issues will be ameliorated. And this happens, and to me, this is just a repetition of the medical model. It's like, okay, you give someone housing, that's not like, they're not like then totally fine. If you give someone money, they're not just like then totally fine. If you feed them a good meal and it's like an organic meal, they're not just then gonna be fine, like a fully adjusted, like kind of problem in living person or whatever you wanna say. So there's a sense that we have to give them the bare essentials, and then they can finally go engage in the psychotherapeutic work. And I'm saying we kind of need to maybe get rid of this kind of Maslowian, I don't really know what it is, Pavlovian, Maslowian or something. This kind of idea that there are certain people that can't engage in meaningful work about what it is like to be them. Does that make sense? So it's it's not like when they get the right amount of calories, then they'll be able to engage in some sort of psychotherapeutic work. But maybe to think about, and we'll have this on the next slide, what it looks like to engage in therapy wherever you are right now. Rather than waiting, pushing it off. I feel like this serves some sort of alternative purpose where we'll push off the work for some moment when we finally gave everyone all the housing they need, all the food they need, all the money they need, all the supports they need, all the relationships they need, all the whatever. And then finally, we'll engage in the work of psychotherapy. And that should be kind of obviously silly to all of us, I think. I don't know if you have anything.
Yeah, and especially because, there are these themes that would emerge across transcripts, across interviews, but sometimes details would come up across interviews that would be, really strikingly speaking to this, but also it's just really scary to look in the face of these repetitions. But something that came up across, I would say, at least 10 of 30 interviews was the fact that sometimes people get housing, they get, their bodies taken care of in this way, and then they suicide, they relapse, and in fact, throwing someone into housing and then say, okay, you have what you need now, that's it, is deadly. It's lethal. And I think that that's a trend across these that we should be really concerned about, because something that happens is people they get the housing, and then some of the access to services and care stops. And this is where street therapy might be helpful, or we should think about it. But also we need to sort of address that crisis, the fact that it comes up so much. Another thing that comes up is it's amazing to have these street psychiatry services that round. It's so powerful. Some people don't want medication, so they don't want that kind of care. And so what are the other options is another sort of reason why we would suggest or try to think about a street therapy program. But also people get offered medications, they start taking them, and then they don't continue with the medication. This is also something that, you know, is alarming and concerning. And there are like detrimental health effects that we heard about. So that's another trend where we need to sort of come up with some long-term solutions where you know, that can be addressed, because just taking care of someone's body in these ways is so important. But first of all, they might not want it. It might not be good for them. It might not be good for their context. And so trying to think beyond that.
Yeah, not quite Descartes is saying, you know, we're not trying to say that there's some sort of split between the mind and body
Right.
or something like that, but they're integrally related. But you can't just like, you know, just decide you're going to do all the kind of behavioral health kind of, you know, kind of medical care, and that's going to solve the kind of subjectivity care or something like that. So I'm going to try to move through these real fast because we have one more slide. So transcendental trauma. So the sense that, like, you know, what do we mean when we say trauma? There's this kind of like broadly people are saying just like trauma causes everything, you know, it's all trauma, everything's trauma all the time, you know. And then you have this, like, one of the participants talked about the theft of trauma-informed care, the sense that, like, yeah, trauma is of course important, you know, but what do we mean when we say it? And then you're like, okay, I don't know, my bus is trauma-informed, or like, you know, whatever these things are, like the lunch is trauma-informed or whatever. And there's no real sense of what that actually really means when someone says it. So, you know, but there's this almost a sense of like, okay, if it isn't biology, then it's gotta be trauma, you know? And so everyone kind of, if they're doing a non-biological reductionistic understanding of psychosis, schizophrenia, mental health, whatever it is, then it seems like then the alternative is then we'll just call it all trauma. And that will be the transcendental, you know, signifier for the causality, the reductive causality of everything. And, you know, phenomenologically and experientially, like, I don't think that holds. And we only really got in our interviews with service providers these brief notices of kind of recognizing the polysemy of what trauma means. You know, mostly they were just like trauma. You know, there was no sense of like what that meant in a kind of more fine-grained sort of way. Prioritizing pragmatics. You know, many of the interviews we had with people, even some who were therapists, is they just like couldn't get out of this concrete headspace. There was a sense in, like, you know, we'd ask people like what they would want to change about things, and they would say any number of things. Like, I don't even want to necessarily get into it, but like, you know, really kind of you know, really concrete. We'd be after an interview, be like, they can't even imagine what another world would look like. It's literally just like, on the one hand, it's crisis centric, you know, and on the other hand, because the places where they work are like basically swallowing up all their interiority all the time, and they're largely just like clicking mouses and doing notes and just trying to like get through the friggin' day. They can't even like begin to think about what hopefully we're able to think about here. And then last thing before go to the next slide, talk therapy doesn't mean talking is therapy. So we'd have a lot of different people who would say like people just need a place to talk. And we'd be like, that's not psychotherapy, you know, or they just need a smoke break, or like, you know, to like, and just like, that's not what I'm talking about when I talk about psycho. They just need somewhere to vent, you know. And these are all from you know, as a psychologist, I'm like, that you know, doesn't quite that's not what we're offering here. So real fast, last slides. So imagining a street therapy program, kind of pithy. First off, so like any therapy for people, anything that looks like psychotherapy would be really wonderful here. I don't know, Anne, if you want to chat about any, or just read these ones off or something, or if you have whatever, but I don't mean to, yeah. So something that's phenomenological experience near, you know, ongoing psychodynamic psychotherapy, you know, something that actually, like, again, looks like psychotherapy that you would recommend to someone that you know, is not taking place. Like, I promise you this, it's not taking place. So if someone comes to you and asks for psychotherapy, you're probably not going to refer them to the places that people who are experiencing homelessness are going to. They're not going to be the same. There's like a class distinction, a poverty distinction. Like, those are the ones that, like, they take care of the homeless people, you know, and you send yours to, like, I don't know, your fellow Duquesne grad who works in Squirrel Hill or the East End somewhere or something like that. There's a difference between the care that people are getting. So frames that are flexible but not free form. So being able to mess with what the psychotherapeutic frame looks like, but not just like all sorts of willy-nilly do whatever, we're smoking cigarettes at psychotherapy. That might work in the kind of relational space to build rapport, but like there still has to be a frame. Not everything can be psychotherapy. You know, eating our biscuit after this or something like that is not psychotherapy. You know, there is a frame that makes the game that is psychotherapy and therapy. So lean into common factors research. I'm not even going to get into it. There's tons of common factors research, you know, that's really important, you know, but the salient part of that is that the relationship itself is as the healing curative factor, and meeting people where they are. If we can take anything from street outreach, if we can take anything from harm reduction, it's that these relationships are powerful and they're healing in and of themselves in a lot of ways. In awareness of institutional resistance, I mean, Nev talked about this earlier. Institutions, they don't want to freaking do this. You know, I almost F-bombed there. They don't want to do this. They don't want to like, they don't want to offer this sort of services because it's like fundamentally kind of, you know, challenging to what they are up to. So I have applying a housing first model here. I wrote therapy first. This is not to say therapy only, the same way housing first isn't housing only. So housing first doesn't mean give them housing and it's all good. But what does it mean if we just start doing psychotherapy? You know, like I've worked in state psychiatric hospitals. I've worked in community mental health. You can do therapy with all the people that looks like this. Like I've done it. You've all done it, hopefully. It doesn't mean we have to like, you know, get everyone in place before we do that. And so a part of transformation of how we understand psychological care, it can't just be psychotherapy in an office. It has to be a part of a kind of communal kind of world societal shift. You know, we do some of this at Point Park. We have the Thriving Respite, you know, Hearing Voices, you know, groups that, you know, I'm trained in and run groups here in Pittsburgh. So it can't just be psychotherapy, but it's across all different modes of care. And then the last one is, you know, and maybe Anna could say a little bit about this too, but a move away from billable services. You know, we had a lot of people talking about the way they'd go find someone that they could bill that was easier to find, rather than someone that's difficult to find who's living on the street. So they could find like Doug who needs like some wound care, and then they could like click the button for like the billable insurance care, and they could like get their services rendered and get paid for it or whatever. But they're not going to go look for Mary who's in the woods somewhere because they can't bill for that. You know, so we would like to think as an imagining a street therapy program, what it would look like to move away from billable service. And for me, maybe away from insurance, like away, you know, like stop eating the feed that they're giving us, and maybe we could imagine what we could do otherwise. And I have towards what, who knows, with what, don't know. There's a lot of smart people in here. Maybe we could begin to imagine some of that. But yeah. Any last bits?
No, that's great.
Okay, cool. So sorry, we had to really burn through that. I was telling Pim 6 slides, and Pim was like, what? You know, like 6 slides? I got 30. And I was like, don't worry, we'll get there.
Is this thing on? Yeah. Well, thank you so much to Anna and Jeremy. We've got about 10 minutes for questions now. So Maria is going to go around and take questions from the audience. Please raise your hand and we'll bring the microphone. And for those who are following along on Zoom, please feel free to put your questions in the Q&A, and I will bring them up for our panelists.
Anna, in your interviews, I'm curious about, like, you mentioned the sort of psychiatric paradigm of, and in my head, it's sort of juxtaposed against this sort of behavioral health paradigm. And not that we need to be doing psychology or something like that, but I hear that that's what's being left out, especially insofar as you guys are talking about, like, what therapy could be. But, like, in the eyes of the city or in the state, what exactly is behavioral health? Like how do people interpret that who are experiencing homelessness, and what does that actually mean in terms of services?
Yeah, and I can say a little bit about that in terms of like the interventions that people talked about, like goal setting and meeting goals is like a #1 priority of behavioral health. And that's not just for folks experiencing homelessness. That also comes from the hospital system. That's super major here that I won't name because I don't know whatever, but you know, it's just look. Sorry. But it's like, you know, like even I work in a community health setting for something completely different, not necessarily just for folks experiencing homelessness. And it's a lot about goals. goals, meeting goals. And we talk a lot about like how folks have, first of all, folks experiencing homelessness might have really different goals than that behavioral health system has for them that they want to meet, that they want to work on. And we talked to a lot of providers who talk about it's so important to prioritize those goals for folks. And that's how you're going to get those goals met. But there's these other folks that the hospital wants you to meet, that the blended service coordinator is obligated to have you meet in order for you to keep your housing. And that's where it gets a little bit more complicated. But you can see like motivational interviewing is a huge intervention here. Again, like breaking down the barriers to meet the goals. It seems to, from our conversations, really loom large, this goal thing. And people experience that as sometimes pressure, definitely barrier to care stuff, you know what I mean? And so, yeah, I hope that says something too. But this motivational interviewing, goal setting, goal meeting thing is so big. Like, talk about neoliberal. Yeah.
Right. Yeah, it's like, I remember I heard in the psych hospital like every day, it's behavioral, it's behavioral. This kind of like as if there was some, it's behavioral, not psychological. And if you've worked in psych hospitals, you've heard this before. It's like as if that's like some, like their behavior. I don't even know what it's, I don't even know what all. But this, I think, is the behavior, this kind of behavioral, science or behavioral, I forget even how I phrased it, kind of worldview or something. Yeah.
I think we're going to take a question from the online.
Yeah, so we have an observation from the Zoom chat that says, a lot of therapists seem to not want to do therapy with people on the schizophrenia spectrum. So I'm wondering if you could speak to that.
Yeah, so I'm trying to think about with our interviews, if people spoke. I mean, there were lots of people, like lots of the people we interviewed spoke about working with people who are diagnosed schizophrenic or with any number of things in the psychotic spectrum. But I don't know that did we really have any of the people that are doing clinical work speak about.
One thing that came up that I thought was kind of interesting is that there is a body of research that says that people diagnosed with sort of schizophrenia spectrum disorders shouldn't be in group therapies. And we actually heard from people that they want group therapies. They think they'd be helpful. Mm-hmm. So that's one interesting thing, that there's ideas of certain interventions that should work for certain populations, or the work should look a certain way. I just had the pleasure of going to a talk earlier where folks were talking about like this person isn't right for the treatment because of their diagnosis. And so, yeah, I think that didn't come up so much for us, but this idea of like, oh, you can't do group therapy, and then folks being like, actually, I think group therapy would be really helpful.
Yeah.
Yeah.
I also just think it's a shame. It's just like, it's like, like that, I don't know how to say it. It's like, I like working with people who would be diagnosed with any number of these sorts of disorders, so to speak, or something. And it's just like a shame that people don't want to work. They don't want to work with people who are diagnosed schizophrenic or psychotic, or, I mean, any number of other things, borderline or anything, because I think there's rich clinical work, and I've had the rich clinical work, and yeah. And we would. Yeah. We would.
I would say that another thing that people really don't want to do, it seems that unless they are specifically dual diagnosis, something that came up a ton was that people don't want to work with substance abuse in any meaningful way beyond aiming towards sobriety. And there's very little harm reduction perspective infused into the medical systems here. So what I think predominantly what we actually heard was people don't want to work with substance abuse in a way where it's not just behavioral. Stop doing that. So that was a huge theme.
Thank you both. This is such a great conversation. My name's Sarah. I'm a street medicine provider in Seattle. So this is great to hear. I'm also a doctoral student, so my research focuses on the intersection of mental health and unhoused populations. And so I'm curious, you spoke a little bit about co-responder models that exist in Pittsburgh, but in Seattle, we experience a lot of sweeps and things like that do take basic needs away from people in a really violent, aggressive, repeated way. So I'm just curious how you've heard about some of that need showing up as like providing psychotherapeutic resources while also meeting basic needs. I know you said the focus can't just be on Maslow's needs, right. But when I interact with folks and I'm trying to provide therapy, the conversation inevitably comes back to, I got my Social Security card thrown away last week. I don't know what the hell I'm doing out here. Like, I'm probably going to die next week because all my money was thrown away and everything I own. So just curious about like, if providers don't want to provide substance use therapy, or work with like really key issues that are intersectional with their day-to-day lives around their mental health? Like, do you see this being an interdisciplinary team, or how do you kind of see that being addressed?
Yeah, so the first thing, I'm immediately lamenting the fact that Cal isn't here to speak about this. I mean, like, I could offer any number of responses about sweeps and co-response teams that would not do your question service. I mean, so I like really actually reach out to Cal. I'll give her I'll give her afterwards or whatever, because she could speak about this at great length and great detail that I can't even begin to imagine. But the way, like, so what's kind of interesting about, or like, fun about imagining a street therapy program is we get to imagine it. So like through the research, hopefully we'll be able to, like, it would be an intersection of all sorts of care. But I think what would be required to be a part of it would be this phenomenological experience near, psychodynamic psychotherapy that is allowable to be long-term. We have people who would speak in, no one graduates from some of these programs. There's some sort of sense in which, like, we wouldn't necessarily graduate someone out. Of course, we terminate if we, whatever, if someone wants to stop doing the therapy, but there'd be some sort of sense in which, like, we actually don't know what we would make yet. This is just like, I mean, like little crumb of an imagining here, but to begin to imagine giving psychotherapy, long-term psychotherapy that is psychodynamic and meaning-based and meaningfully impactful is non-existent. Like we've looked at literature. There's some little people here and there who are doing it in these kind of like little silos, but largely it's not taking place. And what that looks like. I invite. Please talk to me about what that would look like. Talk to me about your communities after we're done talking. Help me, in a kind of informal way, imagine this, because I think we're going to have the opportunity to make something like this in Pittsburgh because it's so kind of service rich. So yeah, please talk to me, please. I might look grumpy, but I'm not all the time, I promise.
So I'm going to take another comment from the chat. I think this one following on the last one. Lizzie says, it isn't always a question of want, I think. It's more about preparedness, education, meaningful connections, and then care while doing the work. How do we address this at the source? So I think this is in a reference to therapists not wanting to work, also about capacity building for people who can and feel empowered to.
You want to go?
I want to keep my job. I want to keep my status.
Let me speak then.
Yeah.
Let me speak. So yeah, so I think if we can learn many things from the harm reduction model and from a lot of the outreach providers. And the thing is, like, you can't do anything without, I think if I'm understanding the question correctly, you can't do anything without rapport. And what that means is making connections and making relationships. So it's like, I have this quote down here. It's like a kind of psychoanalytic trope, but you don't know what you need until you get it. And there's the sense that, like, lots of people say they need things or want things or don't want things or whatever. And then when you actually get care, you're like, oh my God, I needed it all along. So, I don't quite know if I'm answering the question from the chat, but
I have a positive reframe for what I was going to say.
Good.
You kind of have to, you
now
can't.
we knew it was a negative one.
You might not be able to find it where you are, and you kind of have to seek it out. And it's like, oh, there's something burdensome to that. But like, we talked to a bunch of outreach workers who were like, I actually am a nurse, and I am actually going to volunteer at a harm reduction place. I'm actually an undergrad student, and I'm going to start working at a winter shelter. Like, you need to seek it outside of your training models, outside of if you're a therapist, if you're going to school to do therapy, it won't be there. So you have to push yourself to find it outside, because exactly what you're going to learn most from is from outreach workers and harm reduction folks. And like, I don't know, like, I'm thinking about, like, I heard about hearing voices and I found you guys, or like, you have to, like, you have to push yourself so hard. Is that fair? Is that just? Does it put the burden on people who are like already having a hard time getting things done? Like, yeah, maybe, but it's not going to be in your academic settings, and you have a group of people who are really pushing themselves to be doing the work all the time in the outreach community. So you can do it too. And I think that that's something that I am learning for sure. Because you're as therapists, you're just not going to learn it at school.
All right, we're going to take another question.
Yeah,
Please.
Yeah, one of the things you're saying is that what's really important here is relationship. Or that's one of the things that can really help people be in a real relationship, caring, symmetrical relationship. So if I was going to do that, if I was going to develop that with a homeless person or some person who is on the street, I would want to be with that person at least every other day, maybe every day.
Yeah.
And I want to really develop a relationship of that kind of intensity. I'll be with you every other day. We're going to be together. We're going to have lunch. We're going to really be together. We're going to get to know each other. But we don't have enough outreach workers or service coordinators or whatever you want to call them to do that. So I'm wondering if this is a problem of scale, in a way, a problem, but we just don't have enough people out there developing these relationships.
Can I say something
Yeah,
to that,
go ahead,
actually? It makes me think about, I think that stories I have heard, and now I'm actually going to talk about someone I consult with. His name is Chris Vanderwees, and he operates out of a mission, out of a church in Toronto. And he works with a lot of people experiencing homelessness and housing precarity. And actually how he started in that role was actually just by sitting and eating with people and coming he was volunteering at the church with folks who were in the church, and he became a part of that community. And then he started practicing psychotherapy, intense psychotherapy, multiple times a week, like you're saying, with people who were from the community that he had just joined. And so actually something I'm thinking about, one way I wonder about rephrasing the question is, it is a problem scale. I kind of wonder if we just don't have enough spaces. We don't have enough spaces like that church that can gather people to sort of address the need and meet the need. And I think Chris is a really good example of how someone found a space and it was able to sort of connect with so many people. We don't have these gathering spaces. And I think that's one problem, because it's a scale problem for sure. But I'm just trying to come up with something a bit tangible to say, well, if we had more spaces where we could gather, we could address folks in that way.
Yeah, I think that's part of it. And I also, as I'm sitting here, I'm thinking like, there's so much money going into these behavioral services. There's so much money going into, like, we're pumping out like master's level clinicians and LPCs and LSWs, LCSWs and PsyDs and PhDs. We're like, the universities are like asking for these programs. Like I teach at them. They're like knocking on the door for these programs. We're training them, and then they're not doing this work. They're doing any number of other work. Which is all important. Everyone needs care. I don't think it's a matter. It's a matter of like what we're training therapists to be interested in. What kind of care we want therapists to be interested in, what kind of milieus we want people to be interested in. This kind of like really rigid frame of what psychotherapy looks like. It's like I was lucky enough, or unlucky enough to have experiences that like brought me towards this work, over the course of my life. And I think that like there are plenty of people, they're just not doing the work, and the county and the state and the city, the amount of money that's going into these things, which is all really great, could be used to making these kind of meaningful, through a cigarette. All the street workers, they smoke cigarettes with everybody. That's what they do. Through the cigarette, you make a relationship, and then everything moves on the fulcrum of a cigarette often. And I think it's a matter of spaces, but I think it's also a matter of training clinicians and workers to be interested in this milieu and not to be interested in some sort of, to my mind, some sort of bourgeois existence that relegates and perpetuates the ongoing immiseration of many people.
On that note, I think we are at time. So thank you very much to Jeremy Northup, Anna Kreienberg, Kala in absentia. And give them a hand, and then we will head over to lunch.